Today, our objective is the en-bloc resection of a right renal Wilms tumor, removing the mass and the adjacent adrenal gland as a single intact unit. To achieve clean surgical margins exactly like you see here, we have to execute a strict, highly sequential protocol. The setup begins with the patient placed flat in a supine position, fully prepped and draped under general anesthesia. Before we begin, we must address the primary hazard of this procedure. If the kidney is manipulated too early, there is a severe risk of catastrophic bleeding or forcing tumor cells into the bloodstream. Because of this risk, the entire pacing of the operation is built around one rule. We must achieve absolute vascular control before the tumor is ever palpated or mobilized. We gain access using a chevron incision, cutting through all layers. Notice we carry the right limb of the incision farther across the abdomen than the left. This animated diagram shows why that extended access on the right side is necessary to expose the specific surgical field we need. Once inside, the immediate priority is verification. We carefully inspect and manually palpate the liver to confirm there is no metastatic spread. Next, we palpate along the great vessels. In this case, we find nothing suggesting nodal spread. With the surrounding area checked, we begin the initial exposure. We mobilize the hepatic flexure of the colon and divide the lateral peritoneum, cleanly stripping the entire colon off the tumor. From there, we cauterize the duodenum, mobilizing it out of the way, which clears our direct pathway over to the vena cava. Confirming clear margins on adjacent structures like the liver and colon is a mandatory gateway. Only after verifying these areas are clear do we move toward the tumor's direct blood supply. Now we approach the critical phase of the operation. We carefully dissect down the right lateral margin of the vena cava until we identify the right renal vein. In this cross-section, notice the highlighted right renal vein hiding the right renal artery directly behind it. We must separate these vessels without disturbing the mass. Once exposed, ligation is strict. We target the artery first, then the vein. Step 1. We tie off the artery using a 2-0 silk suture. Only after the artery is secured do we tie the vein. Warning tone: remember the primary hazard. Do not palpate or mobilize the kidney itself until this specific step is entirely complete. Securing this vascular choke point traps the tumor's blood supply. This neutralizes the risk of sending malignant cells into the bloodstream when we mechanically extract the mass. With the blood supply controlled, we carry the dissection down to the vena cava, extending beneath it, over the top, and all the way across to the aorta. As we move down the iliac artery and vein, we encounter a dense, highly vascular plexus surrounding the right ureter. We methodically ligate each component part of this plexus in turn. Once this mass is divided, we ligate the ureter itself. The resection then moves up the back of the right kidney. Along the great vessels, we meticulously clip the lymphatics to prevent leakage, ensuring a dry field. As shown clearly here in this sequence, we use clips to rapidly secure bleeding points the moment they are encountered. We then approach the upper pole of the kidney. We apply clips and cut between them to free the adrenal gland, allowing it to be delivered intact with the tumor. For the final severance, we doubly clamp the main artery and vein and cut between the clamps. We apply a number 2-0 silk suture ligature to both stumps, and then deliver the entire tumor to the back table. We conduct a thorough hemostasis check. In this instance, we place a single number 60 proline suture to secure a minor bleeding point on the cava, bringing the bleeding under complete control. This exacting sequence of clipping, ligating, and en-bloc extraction is designed to ensure no microscopic disease remains in the surgical bed. Satisfied the right side is clear, we place the right colon back into its appropriate position and tack it in place using interrupted number 40 silk sutures. Next, we address the secondary cancer check. We mobilize the left colon and completely strip Gerota's fascia away from the left kidney. This split screen compares our empty right surgical bed with the fully exposed left kidney, which we can now directly visualize and physically palpate. We confirm there is no suggestion of a tumor on the left side. With verification complete, we replace Gerota's fascia around the kidney and return the left colon to proper place. We then pass a nasogastric tube and confirm its position. The internal closure proceeds layer by layer. The inner muscle layers are closed as a single layer using interrupted number 0 ethiflex and a figure of 8 fashion, followed by the outer muscle layer with a running number 0 CCG suture. We irrigate the wound with neomycin bacitracin, Close the subcutaneous tissue with running number 30 plain gut and apply skin clips. Notice that no drains are used. This decision, along with the precise anatomical closure, reflects total confidence in a completely hemostatic surgical field. The patient tolerated the procedure well. We successfully resected the right renal Wilms tumor and the adrenal gland en bloc, achieving total hemostasis. As the procedure concludes with these final skin clips, the patient is transferred to the recovery room in good condition. The resected tumor is sent to pathology. Their analysis of the specimen will determine the definitive staging of the disease. Securing the blood supply before making a single move on the mass, combined with strict anatomical verification, allows us to safely execute a highly complex oncologic resection and produce a predictable outcome for the patient.